I'm Dr. Connolly. I'm a neurologist, movement disorder specialist, affiliated with McMaster and Hamilton Health Sciences. I did my residency here at McMaster in neurology, and then I went to Toronto to do my movement disorder fellowship. And I'm speaking today about challenges in advanced Parkinson's disease. So advanced Parkinson's is sometimes called late-stage Parkinson's as well. Oops, so what did I do? Oh, left one, didn't it? I wanted to just first, before I get into some of the symptoms I'm going to speak about advanced Parkinson's, to talk a little bit about the progression of Parkinson's and kind of build a little bit on Dr. Montgomery's talk about that and how we manage people's symptoms as they progress through their Parkinson's disease. So in early Parkinson's, people are in a honeymoon period, we call it, where oftentimes they take their medications just 3, maybe 4 times a day. They're on a relatively low dose. They often can be late with a dose or miss a dose and really not notice any worsening of their symptoms. So this is usually a time when they remain in the on state most or all of the day. In moderate Parkinson's, people, which starts around 4 years after diagnosis, people with Parkinson's disease start finding that the medication's wearing off, and they're noticing that their symptoms are returning before their next dose is due. They may also develop dyskinesia, which I describe as wiggly movements that can happen when the dose of medication is a bit too high in the blood. Finally, in advanced Parkinson's disease, people sometimes have unpredictable symptoms. So rather than knowing that when they're almost ready for a dose of levodopa, they may start to notice that their symptoms will return. They may find that in the middle of a dose, all of a sudden they're just in the off state. They have their stiffness or slowness or tremor back, or a dose doesn't work at all for them all of a sudden. So these are called unpredictable off times and can be very disabling for people. People also in this phase may have more dyskinesia as well. So people with wearing off can have motor fluctuations where they feel like there's stiffness and slowness and tremor may return between doses. They may also have other problems as well as those more classical ones. So some people develop dystonia where their toes want to curl or their big toes go up in the air, and that can be very painful. And some people develop non-motor fluctuations where when they're due for a dose or their next dose hasn't quite kicked in yet, they experience anxiety or pain or even sweating, breathlessness, palpitations of their chest. So these types of symptoms can be very bothersome as well. And to manage these sorts of fluctuations, we do lots of different things. One is probably the first thing that we tell people is they've got to be strict with the timing of their medication. You can't be missing doses or being a couple hours late with your doses anymore. You have to be on a clear schedule. We may adjust the levodopa dose, maybe go up on how many pills you take at a time or have you take the medication more frequently. We may add other medications, so those MAOB inhibitors Dr. Hall mentioned, selegiline, rasagiline, help to prolong the duration of effect from levodopa. COMT inhibitor, which is entacapone, also called Compdan, also does that. So a lot of people, when the medication just isn't lasting long enough, we add entacapone so that we don't have to change the timing. The entacapone gives each dose a longer action of effect. We may add in dopamine agonists. So you can see there was a bit of a debate today about which one do you start with first, levodopa or dopamine agonists. And again, there's lots of criteria that go into that decision. But some people are on levodopa, and then we add dopamine agonists later to try to smooth things out. Sometimes we add that controlled release or long-acting form of levodopa overnight, and that can give people a control of their symptoms overnight so they don't wake up in the middle of the night or in the morning with a lot of stiffness and troubles walking. Dyskinesia can be very disabling, but most of the time it's not, and a lot of people have just very mild dyskinesia. Can you turn on the video there, or do I have to turn it on here? Okay, there we go. Okay, here we go. So dyskinesia is most often due to your drug levels of medication being a little bit high. This person has very severe dyskinesia. I rarely see someone with wiggly movements this bad. It's not a symptom of Parkinson's, and people not in the world of Parkinson's don't know that. They think this is Parkinson's, but this is a side effect of medication. And it happens in quite a number of people who have Parkinson's over the course of their disease, but like I said, most people don't look like this person. They may have their head moving a little bit, or a foot moving, or one side of their body. And a lot of people would rather have a bit of dyskinesia more than their Parkinson's symptoms of slowness and stiffness and tremor. So it's often a balance of trying to decide how to manage it best. But sometimes we do reduce the dose of levodopa because this can diminish dyskinesia. Or we can add amantadine, which works often quite well for controlling dyskinesia. There's also some more advanced therapies for Parkinson's. You've heard already about deep brain stimulation surgery and briefly about the Levodopa-Carbidopa intestinal gel. There's also a couple of others, apomorphine and MRI-Guided focus ultrasound thalamotomy, which is a mouthful, and I'll talk about each of those very briefly. So first, deep brain stimulation. Again, I think my colleague mentioned this in quite a lot of detail, so I won't go into a great amount of detail, but we don't do it here in Hamilton. We refer people to Toronto or to London. And the groups in Toronto and London do have quite strict criteria for who they consider a candidate for deep brain stimulation surgery, and not everyone is. Age is not an absolute cutoff, so they have done people 75. There are people who are 80 years old and have had deep brain stimulation surgery. And it's generally for people who have a lot of dyskinesia, a lot of tremor that hasn't responded well enough to medication, or they're going up and down throughout the day in terms of their symptoms and have to take their medication very frequently. There are some cognitive contraindications. I think you heard from my colleague as well there are contraindications, often cognitive issues or thinking and memory troubles, a lot of speech issues. Oftentimes we won't do surgery on someone who has a lot of speech impairment because it can worsen. If you have major psychiatric issues, that may also worsen after surgery. Benefits though, bradykinesia, that slowness improves, rigidity and tremor. People have less off time after deep brain stimulation surgery, and often reduce their levodopa dose, which leads to less dyskinesia. But intracerebral hemorrhage, strokes, speech and gait deterioration, depression, and cognitive decline could all happen after surgery. The Levodopa-Carbidopa intestinal gel, which is called LCIG, has been around now for probably 5 years or so in Canada, although it's been around for about 15 years in Europe. It involves placing a tube into the gut and then delivering levodopa in a gel form right into the gut continuously. So you stop your oral medications, and this is connected in the morning and disconnected at night. So you use it for about 16 hours per day, and it helps maintain a continuous supply of levodopa, so you don't have the ups and downs that you do have with the pill. Some people find this an incredible treatment because they're not stuck to their timer anymore, but it's not for everyone, as you can imagine. Not everyone wants to carry around a pump. And the government does pay for this treatment, but you have to satisfy quite a strict criteria as well, which includes at least 25% of your day has to be spent in the off state, so feeling slow and stiff, despite all the medication changes, and you have to have tried all the different medications for Parkinson's disease first. I'm going to just kind of go through this, past this one. This, just like deep brain stimulation, the LCIG does reduce the amount of off time, and it reduces the amount of dyskinesia as well, because people aren't having the ups and downs. They don't have the peaks that lead to the dyskinesia. So oftentimes dyskinesia does improve, although it doesn't usually go away completely, and improved quality of life occurs after this treatment for a lot of people. Apomorphine is a dopamine agonist that has a special use. It has a very quick onset of effect, and it doesn't last that long. So it's for people who need a boost of their medication, or a quick improvement to their symptoms. So for example, in the morning, if you're very slow and stiff and you're waiting for that first dose to kick in, apomorphine may be helpful for that. Or in unpredictable times when all of a sudden you find yourself in the off state. In Canada, we now have a injector, a subcutaneous, just injector that is available, but it's not quite organized in terms of how to get it to patients, because there's some monitoring that's required when you use it. So it's kind of still in the works. They're coming out with a film that you put under your tongue, and I think that'll be quite convenient for people. So you put it under the tongue, and then it works within 20 minutes or so. And then there may be in the future also a pump for this that goes kind of subcutaneously under the skin that gives you more continuous action. The MRI-guided focus ultrasound, this gets a lot of press in the news. People just find this very interesting. It is a surgery, but it's an incision-free surgery where you don't actually have to open up the skull and put in wires. Basically, they shave the head and put an ultrasound-type device against the skull, and the ultrasound beam goes through the skull and burns a hole in the part of the brain that's causing symptoms. So it was first used for essential tremor, mostly for tremor, and now they're just starting to use it for Parkinson's too. First for tremor and maybe for other symptoms, depending on where they burn the hole in the brain. So it's somewhat experimental in its use for Parkinson's now, but there is a lot of research, and it's something that you may see more in the future. So in terms of my regular talk here that I wanted to describe to you, so I'm going to be talking more about advanced Parkinson's and some non-medication and medication methods for managing symptoms of advanced Parkinson's. First, a lot of people ask me about the stage of Parkinson's. What stage are they in? I must say, I don't pay a lot of attention to this. It doesn't help me care for my patients any better. But just so you know, we kind of divide it into 5 stages. In stage 1, there's just very mild symptoms on one side of the body, and oftentimes people have minimal to no functional impairment. Most people actually don't see their doctor when they're in this stage. Their symptoms are so mild that they don't seek medical attention. It's usually around stage 2 that people go see their doctor about their concerns, and during this time, people may have developed that facial masking, that reduced facial expression that some people with Parkinson's have, a quiet voice as well, and they have symptoms on both sides of their body. Stage 3 is considered mid-stage Parkinson's, and during this period is when people start noticing that their balance isn't as good as it used to be, but they remain fully independent. And stages 4 and 5 are kind of considered advanced Parkinson's disease, and during this time people's mobility deteriorates, and oftentimes they require use of a walking aid like a walker, and they have trouble getting out of bed and moving around without some assistance. But there is no real agreed upon definition for what is advanced Parkinson's. When do you know you will have advanced Parkinson's disease? But I must say that this can be a very challenging time for many reasons. And one of them is that people with advanced Parkinson's often have symptoms that don't respond to levodopa. Whereas earlier on, you can change the dose and modify things, and people's tremor diminishes or their stiffness or slowness improves. A lot of the symptoms that people experience at advanced Parkinson's just don't respond to levodopa changes. Most people with advanced Parkinson's have had disease for more than 10 to 15 years, although there are some people who have had Parkinson's for 20 or more years and still do not have advanced Parkinson's. So some people do very well long term. These are some of the symptoms of advanced Parkinson's. So falls and freezing become more of an issue. Autonomic disturbance, so these are the automatic kind of functions of the body, urinary incontinence, that orthostatic hypotension or the blood pressure dropping when you stand up, and drooling become a problem for some people, nighttime sleep disturbances, psychiatric symptoms like hallucinations and psychosis, cognitive impairment, and swallowing difficulties. First about cognitive impairment, so everyone, as we all get older, we struggle a bit with our memory. That is totally normal. It may take longer to retrieve information, but most of the time, the word that you're looking for should come, or the phrase or whatever. And with mild cognitive impairment, people have mild difficulties with their memory that are outside of normal aging, but they're still functionally normal. So they're able to function in their day-to-day life without difficulty. Dementia is defined as people who have cognitive issues or thinking or memory issues with functional impairment, with difficulty managing day-to-day. At least 80% of people with Parkinson's develop mild cognitive impairments or mild symptoms, and even at the time of diagnosis, some people have this complaint. And some of these people go on to develop dementia, but not everyone. And people with Parkinson's disease who develop dementia have what we call Parkinson's disease dementia. Unfortunately, people with Parkinson's aren't immune to getting other neurodegenerative diseases, so people can get Alzheimer's too, which I think is totally unfair to be able to get both conditions, but that happens. Some people get vascular dementia, dementia related to strokes in the brain. Some people get a mixed picture, so multiple different types of dementia. And at the bottom here, I mentioned dementia with Lewy bodies. So sometimes people say, well, if my loved one has developed dementia, is it now dementia with Lewy bodies? Well, dementia with Lewy bodies is almost kind of like, I call it the other side of the same coin. And people with dementia with Lewy bodies have the dementia first, and then they get the Parkinsonism, the slowness, stiffness over time afterwards. So if you develop dementia after years of Parkinson's, that's Parkinson's disease dementia. Does it really matter? Not too much. There's nuances to the difference in how we manage them, but they're very similar. And there are features, so Parkinson's disease dementia is a little different from Alzheimer's. People don't usually have as much memory complaint as people with Alzheimer's disease. They may have more visual-spatial difficulties, so that's ability to kind of judge the world and organize themselves. So driving, which really relies on visual-spatial skills, can be quite affected in people with Parkinson's who have dementia. They may have more impaired judgment and decision-making abilities and inattentiveness or poor ability to concentrate. So the first thing to do is remove any contributing factors, either mood conditions or psychiatric illness that could be contributing, physical diseases, treat thyroid issues, vitamin B12 deficiency, because these things contribute to cognitive impairment. And then eliminate any medications that could also be contributing to confusion. And this could be non-Parkinson's medication, like bladder medications or sedatives at night, and some Parkinson's disease medications as well. And dopamine agonists can contribute to confusion. So if people are complaining of that or showing signs of dementia, we often slowly withdraw dopamine agonists at that point. Unfortunately, there are no medications known to slow down cognitive impairment. And we have medications, though, that for some people do enhance cognitive function a bit. I must say I find the effect quite modest, but we do try this class of medication called cholinesterase inhibitors to see if that can help people a bit in terms of their cognition. The best evidence is for one called rivastigmine, so we often use this one, and it can cause stomach upset for some people and changes to heart rate that have to be monitored. But in Parkinson's, the unique potential side effect is it can worsen tremor. So if you're placed on a cholinesterase inhibitor, pay attention to whether you find that your tremor is worse. I always harp to my patients about brain health and brain exercise, and just like Orla Harris is going to speak about physical exercise, you have to exercise your brain too to keep it strong, keep those connections between the neurons strong. So learning something new is really great for the brain, a new language, a new instrument, take up a new hobby. It's almost painful to do these things, but that's why they work, because they really do strengthen the brain. And also, your brain is at its best when it's healthy. So we can't control the Parkinson's disease, but you do have some control over whether or not you get strokes or other things like that contribute to the brain not functioning normally. So treating high blood pressure, high cholesterol, diabetes, treating abnormal heart rhythms, avoiding smoking, keeping your alcohol intake low, and doing physical exercise are all very important. So I think my colleague this morning might have mentioned orthostatic hypotension, but this is when the blood pressure drops when you stand up. And some people have a little bit of this, but you have to have a 20-point drop in the top number or a 10-point drop in the bottom number for us to think it's significant. And this happens in a lot of people with Parkinson's, although when I pose this question to my patients, a lot of them say they don't notice this. So people may have this problem without even being aware, and that means that they may not, this could cause falls later on if we don't make them aware of it. So we do check blood pressure in patients on a pretty regular basis because of this. These are some of the symptoms of orthostatic hypotension, things like lightheadedness, blurry vision, sweatiness, confusion, weakness, all can happen. And of course, this when you're feeling all weak and dizzy, you're prone to falls and physical injury, so that's the main concern. There are a lot of strategies for helping manage this problem: drinking more water, avoiding getting up too quickly, adding salt to your food, wearing compression stockings can all help. If we try all these, sometimes I get people to raise the head of their bed 4 to 6 inches. So I'm sorry for the people at the back if you can't see the little picture, but this is not like a hospital bed where you bend at the waist. The whole bed has to be on an angle. So you put cinder blocks or something at the head of the bed to put the whole bed on a slight angle, and that seems to help to some extent. There are also a bunch of different medications that can help with orthostatic hypotension. Levodopa itself can cause this problem for some people, so we use domperidone in those cases, and then there's a bunch of others I mentioned here as well. Some of them cause your blood pressure to run a little high when you lie down, so you would be cautioned to avoid napping and lying down after taking some of these medications, because you could go the opposite way and have too high a blood pressure in those cases, which is something to be cautious about. Unfortunately, some people, we try everything, and this is a huge issue. It's a rare person, but sometimes we really struggle with this, and I have people who have to be in a wheelchair a lot of the time because this is such a big problem. Hallucinations and delusions. So hallucination is when you see or hear things that other people don't. It's usually how I describe it. And a delusion is when you have a false belief. And hallucinations, the most common is a visual hallucination where people may see their grandchildren in their apartment or dogs, in their bedroom. Some people have a sense of passage, which is someone kind of walking behind them. And some people have a sense of presence where they feel like someone's in the room with them. Auditory hallucinations, so hearing-based ones, are quite rare. Delusions sometimes are more bothersome. Some people have paranoid delusions where they feel, for example, that their spouse is having an affair, and that can cause a lot of damage to a relationship. So that's something that we do see, we take seriously. Hallucinations can be caused by Parkinson's itself. So it's not necessarily the medication. Having Parkinson's puts you at risk for hallucinations, but the medications can exacerbate that risk. But so can other medications, other infections, other life stressors. Anything out of the ordinary to the body can lead to the development of hallucinations in the right person. And hallucinations are the strongest predictor for nursing home placement. So when they're a problem, we need to manage them well. They can occur in up to 70% of people in advanced Parkinson's. But they really only need to be treated if they are causing a problem with quality of life and causing distress. So if someone's happy seeing their deceased husband sitting reading the paper on his couch, as I had a patient the other day tell me, that's okay. That's not hurting anyone. So we might just monitor that over time. There are lots of non-medication related things you could do. Make sure that there's lots of light on during the day. And if you're up in the middle of the night, turn the light on, kind of orient yourself before going to the bathroom, because that's often in the darkness when you're kind of confused and groggy, that's when the hallucinations will happen. And sometimes we have to start removing Parkinson's medication. We try to keep levodopa alone, and first we get rid of the amantadine, then maybe the dopamine agonists, and then the selegiline or rasagiline, because these medications, although they're helpful, they're not absolutely necessary. So we really try to simplify things if hallucinations are an issue. We may then add a medication called quetiapine. There's another medication available called clozapine, but you have to be monitored when you're on this medication, and only certain doctors are allowed to prescribe it, and so it's very challenging to get. So we tend to use quetiapine in most clinics. There are some antipsychotics, or that's what these are, that you shouldn't use. So I've listed them in the middle: risperidone, olanzapine, haloperidol. Anything really but quetiapine. So I have had patients who have developed hallucinations on the weekend. They've gone to the emergency department, and the emergency room physician is not aware of this and places my patient on one of these agents, risperidone or haloperidol, and then their Parkinson's gets worse because these medications can worsen Parkinson's symptoms. So if this happens to you, suggest that you use quetiapine, or tell them about this concern. Final topic is about falls and Parkinson's. So this is one of the major sources of morbidity or kind of illness and disability in people with Parkinson's disease. The falls occur in, I would say, around 50% of people with Parkinson's disease. And if you've had one fall, you have a 50% chance or so of having another fall within 3 months. And about 30% of falls lead to a serious injury. And not only falls can lead to injury, but they change someone's life dramatically. Oftentimes people who fall become quite fearful. They stop going out, they stop moving, they become weak, they may get osteoporosis, they may become socially isolated and depressed. So that's a big issue. And falls can be because of a lot of different issues in Parkinson's: the orthostatic hypotension, just general weakness, the shuffling gait, wiggly movements, the dyskinesia, the instability that can happen in Parkinson's, and freezing. That postural instability is one of those cardinal symptoms of Parkinson's that Dr. Paul Seth made a mention at the beginning of the afternoon. About 90% of people with Parkinson's develop postural instability or imbalance by about 15 years. And this is associated with falls and loss of independence. And unfortunately, this problem does not respond to levodopa for the most part. So people develop those balance issues. Adjusting levodopa is often not the answer. And for most people, it's physical exercise. That is really the thing that people have to do to try to manage postural instability. Freezing of gait is another concern for some people. It doesn't happen with everyone. This is a gentleman with some freezing. You see that his feet get stuck to the ground as he's walking. Oftentimes people start having freezing when they're getting up and getting moving, so just when they're initiating movement, or when they're turning, or when they're going through a hallway or a doorway. But over time, some people, like this gentleman, gets it just in an open surface, open area. A lot of what we do to manage freezing is little tricks, and they're personalized little cues or tricks that people have to learn to manage freezing. So these are some examples of things I tell people. Count 1, 2, 1, 2 to get your feet moving. Sing a little tune, and you know that when you get to a certain part in the tune, that's your cue to get going. Some people have to step in one spot, or step over a line or a foot, or step sideways first to get moving. There's canes and there's walkers that have laser pointers on them, and some people step over that laser to get moving. I have some patients, I think ones who play soccer, who kick a soccer ball first, and that kind of kick kind of triggers them to start moving. Tapping the side of their leg can get people going sometimes. And then some people need to have some home adjustments like safety rails, making sure there's enough light in the room, removal of obstacles that are getting in the way, and planning your schedule based on times where you think freezing may occur. Sometimes we do fiddle with the dose of levodopa to see if going up or going down can help. Sometimes it helps a bit, sometimes it doesn't. Those memory pills I mentioned, cholinesterase inhibitors, there's some kind of weak evidence that maybe they help a bit with freezing. And methylphenidate, which is also Ritalin, the drug for ADHD, or attention deficit hyperactivity disorder, may help a little bit with freezing too. So we've started trying that to see if that helps for some people. And then there are surgeries that some people use to help with freezing, although again the effect isn't very robust. That's my talk. Thanks everyone. So